So good afternoon, everybody. Great to see the venue filling up. We think we have maybe the most intriguing discussion coming up now. So I don't know if you know this, but every second someone aged between 30 and 70 years dies prematurely. And it still seems to be some misunderstanding. Some people still think this is diseases by the affluent. NCDs is actually 78% of NCDs deaths early is actually in the low and middle income countries in the world. So 7 in every 10 deaths worldwide is because of non-communicable diseases. And in a moment, our Assistant Director General, Dr. Svetlana Akselrod, will take the floor soon to tell us a little bit more. I think we are in an extremely happy moment because, as you probably know, the UNGA just had its high-level meeting and we got a declaration. And why is this important? This is actually important because it's the heads of state and government, meaning the presidents, that actually come into action. So this is different from when we have decisions in the World Health Organization and in the Assembly, which is more like a guidance. So I would like to, with a big pleasure, to invite Dr. Svetlana Akselrod to the floor. And she is from the Russian Federation. She has been Assistant Director General for the last 1.5 years. She has a huge experience in public health coordination and also were an earlier Deputy Director of the Department of International Cooperation and Public Affairs in the Ministry of Health in Russia. The floor is yours.
Is it okay? Yeah. Thank you, Bente, very much, and thank you for introducing me. So it's a great opportunity for the WHO to be invited for this very important and timely summit, and I want to congratulate with the 10 years of successful collaboration between WHO and the World Health Summit, and it's a great pleasure for me personally to participate here. I was participating for the several times, as Bente said. I was representing Russian Federation, and now in my new capacity as Assistant Director General for Non-Communicable Diseases and Mental Health, it's a really honor for me to be here. So I have a short statement here to say what it is about and how the important role of the WHO in the achieving sustainable development goals. So, distinguished guests, colleagues, and public health, ladies and gentlemen, I am delighted to be here with you today to discuss how we can translate into action the commitments made at the recent high-level meeting on NCDs, which was taken on the 27th of September in New York. Although this was the third time when this critical public health topic has been brought before the United Nations, and it was first time the fighting against NCDs has been reviewed in the context of the 2030 Agenda for Sustainable Development. Presidents and prime ministers from all around the world assessed this progress in the fighting against NCDs, and they acknowledged that some progress has been made, but also that is very uneven. We have much more to do, and we must do it more quickly. The Sustainable Development Goal target 3.4 is really very ambitious, and deadline is looming. And if we are going to reduce by 1/3 by 2030 the premature death from NCDs, we need to focus in immediate implementation on what we already know and that it works. The political declaration, which was adopted during the high-level meeting, reaffirms the commitments previously made. But there are also 13 new commitments. I don't want to take your time and to go through all of them, but I want to just highlight the most important. And the most important is to provide leadership for the domestic NCD agenda. This is a direct result of the top recommendations from the WHO Independent High-Level Commission, which was established by Dr. Tedros, the Director General, in the last year. The secondly is to implement policy, legislation, and regulatory and fiscal measures. This is directly relevant to the WHO's best buys and other recommended interventions for NCDs, especially raising taxes on tobacco, alcohol, and other health harmful products. Especially relevant to the topic of our panel discussion is commitment to implement interventions on health, overweight, and obesity. A related commitment is to engage with the private sector, including the food and beverage industry, to increase their contribution to the Sustainable Development Goals targets. And there are also commitments to respond to the needs of the rapidly aging population and to address the effects of indoor and outdoor air pollution and other environmental factors. In light of these new commitments, I believe that we are now ready to accelerate actions against NCDs and in integrated manner. We must first, continue to encourage countries to implement the best buys, and they have been designed to be affordable and doable for all countries, even always the poorest. The degree of participation of enthusiasm demonstrated in the high-level meeting clearly shows that tackling NCDs is now a major global political priority. And I'm confident that if we can leverage these political commitments led from the high-level government and ensure that it is translated into new policies and programs on the ground, we will see the dramatic reduction of NCDs. I don't have to convince anyone in this room that there is a strong civil society movement, including people living with NCDs, and that will really help us to keep attention on NCDs and will demand result. We know what works and what we should do, but some countries will need help to do this. And we want domestic resources to be the mainstream of NCDs financing in most countries, but it is, of course, possible. Countries themselves should earmark funding at all levels of government to spend on technical support, training, implementation research, and capacity building initiatives. There are more donors, and national governments must look at ways to invest in the overall health system so that everything from infectious diseases like HIV and TB, as well as NCDs like obesity and diabetes, can be tackled quickly and effectively through the integrated response. So I'm looking forward to hearing your ideas and how we can use our enthusiasm and move the NCD agenda. So I think we will have now a productive discussion led by Bente Mikkelsen, and then we will continue our discussion. Thank you.
Thank you very much, Svetlana. So you have set the scene. So I would like to introduce myself. It is an honor for me to be sharing this debate. My name is Spencer Mickelson. I'm a director for NCD and promoting health through the life course in WHO Copenhagen. I've been working in WHO HQ Geneva for 5.5 years and had the pleasure to establish the first ever global coordination mechanism for NCD. So that's my background. And I would like to introduce the rest of the panel as well. And First of all, we have Dr. Marlene Hendricks, Medical Director, PharmAccess Foundation from the Netherlands. She's a Medical Director for PharmAccess Foundation. And this organization, as I understand, I'm sure we will be learning more, is dedicated to connect more people to better healthcare. So this is really giving the perspective on new methodology, how technology can help us. The next panelist is Dr. Amir Hussain Takian. He's chair and professor at the Department of Global Health and Public Policy and also vice dean for International Affairs and School of Public Health in Tehran University of Medical Science, Iran. He has a bunch of other roles as well, and I'm sure he will be commenting on them. And of course, he comes both from the government of Iran, which is one of the fast-track countries when it comes to progress for NCD, and also a well-known academician. We are very pleased to have a representative from the civil society, and that is Professor Dr. Gerald Yonga. He is a board member of the NCD Alliance and chair of the East African NCD Alliance in Kenya. And he has a rich academic and also governmental background. And last but not least, we have Dr. Anders Nordström. He is the Ambassador for Global Health, Ministry for Foreign Affairs, UN Policy Department in Sweden. And he has served and serves on several boards of UNAIDS, Gavi, and also an alternate board member for Global Fund, and has also been acting as Director General at one point in WHO. So a really rich panel. And we are going to run this session in the following way, at least that's what we plan. So we will have a couple of questions that all the panelists will be commenting on and answering, and then I will open the floor. And so far I have seen in this summit that we have a really active audience, so I hope we can profit from that. Then we will have a second panel discussion, same style. So that's what we plan to do. So I'm just now posting the questions to you, and of course, linking back to what Svetlana already told us, it is a golden moment. So my question to you is, how will you, from your different perspectives, drive progress for NCD, given now the high-level meeting, and also the link between this high-level meeting, the political declaration, and the SDG goals? So how will we actually achieve the goals in NCD, which is probably completely necessary to be able to achieve the SDGs at large? And the second part of the question is about accountability. Did we get any help to actually set out accountability through this process, or what can we do? So I will just pass the microphone, and we start with you.
Thank you. So, like you already said in your introduction, I come from an organization that is focused on technology and mobile solutions to scale up the NCD response worldwide, amongst other things. Let me start with saying that there are already 1 billion people with hypertension worldwide, and there are just not enough doctors, and there's not enough money to treat only this group of people. So we need new ways of care delivery. And to give an example of the country where we work a lot, Kenya, everyone in Kenya has a mobile phone. Not a smartphone, but at least a simple phone. And Kenya is the most prominent mobile banking country worldwide. In Kenya, the M-Pesa platform started, which is a financial mobile banking platform that currently is being used by 95% of the Kenyans. So people use it for financial transactions, and it did a great deal for financial inclusion. And what we thought, together with two partners, CarePay and Safaricom, the telephone company that founded M-Pesa, we thought, can we do the same for healthcare? So we started the MTBA platform, which is basically a mobile health wallet on people's phone. And they can use it to save for healthcare, to receive insurance, to get benefits from donors. And every time a person goes to a clinic, we get data on diagnosis, treatment, cost, and outcome. Now, we started in 2015 with support from Pfizer, Gilead, and the Dutch Ministry of Foreign Affairs. And we now have 1 million users in Kenya and almost 450 clinics. Now, that's just the platform. But we thought, how can you also use a similar platform to provide mobile healthcare services? So we just launched a program together with Sanofi that aims to give people affordable care for hypertension and diabetes. So what we do is we give people in their wallet benefits for hypertension and diabetes care, and they get all these services. So they get a mobile service to self-manage their condition, to track their glucose, to track their BP. They get support on lifestyle, on adherence to care plans, and all the data go directly to the healthcare professionals, and we use the same data for them to give decision support on guideline adherence, to manage their population from a distance. And we think these kind of low-cost models are really essential to bring down the cost of care. And hopefully after this pilot, we'll have a model that can be scaled throughout the world.
Thank you, Bente, for the question. Stop me when I am talking too much. I come from a country with 80 million population, almost 81% of whom die from NCDs. And you can see that out of 16 million of deaths globally to NCDs, 2/3 of them happen in low and middle income countries. My country is upper middle income country, so you can imagine that we are among those people. Compared to high income countries, more people die from NCDs. We understood this, and based on the framework, the Global Action Plan of WHO, and the framework that the WHO has, in terms of governance, healthcare, surveillance, and information system, Iran has done tremendous efforts in the course of last 4 years to address this main killer of NCDs. We have a motto at the Ministry of Health and Medical Education saying to everybody that we are not that rich not to tackle NCDs. Because as Bente said, NCD is the main challenge to sustainable development goals. In order to do actions on those 4 dimensions, first of all, in terms of governance, in 2015, we managed to have the National Action Plan for Prevention and Control of NCDs. And I'm pleased to say that this action plan was endorsed by the highest authorities in Iran, and this is among the most cited and most endorsed at the highest political level of the country among any kind of document, let alone the health policy documents. This helped us to set the scene, and then we used the opportunity of our multi-sectoral collaboration, which I come to that in the second part of my talk, that it is Supreme Council for Health and Food Security, led by the President of the States and 8 ministers involved in that, then to endorse and establish provincial and local mechanisms in order to reach out the whole population for NCDs. And this helped to be very, very useful. The second thing is in surveillance. In order to, and the UN General Assembly, which happened just a few weeks ago, and the high-level meeting helped us because Iran, as you know, we were recognized by WHO officially as the fast-track country back in 2016. A few months ago, 3 weeks ago, on 27th of September, Iran was awarded the UNITAF Award for Global Action Plan and National Action Plan of NCDs. This helps the governance of that and to put more money and more earmark money. We have officially written to the Director General of WHO that Iran is committed, in addition to other financial resources, to allocate 450 million euros annually for the purpose of tackling NCDs and specific programs. As you know, we are enjoying a very extensive primary healthcare program. Building upon that, on our healthcare, which is the third dimension, we are now reaching out all population very proactively in terms of, for instance, risk score assessment, early detection of NCDs, provision of essential medicine for people, and then more importantly, to make people more accountable socially, we are increasing health literacy and the culture of self-care by educating people, using and asking the reference people like celebrities, athletes, academics, and actors and actresses in order to tell people how important NCDs are in order to reach the sustainable development. One good example which I want to mention is, in Iran we have almost 8 million students in schools. 2 million of these students, some students at the age of 5, 6, little girls and boys, those are our health ambassadors. I don't know whether Bente has seen them when she traveled to Iran. In each school, those little girls and boys are taught to go home and to their own community to teach their parents, to preach their families and relatives and friends that smoking is bad. Eat a healthy diet is very important. We try to somehow teach them from the very beginning stages that NCDs are the issue of now and future, so they have the taste and they have the understanding to change their own futures, and we call them health ambassadors. And we have other examples which I come to that in the second section, and most importantly in the last part, which is surveillance. In terms of surveillance and research, I believe we cannot have any NCD plan which is helpful for the country unless we have good data. We have been quite privileged since 10 years ago to establish the research center which works on NCDs and the risk factors of NCDs, and then we have robust data both at the national and subnational levels to know the risk factors of NCDs, what is the best strategy to tackle NCDs in the country, and building upon that, we have reached out to the community and we have somehow strengthened our capacity in order to address the NCDs and risk factors of NCDs. Hopefully by 2030 our national action plan asks us to have 30% reduction of NCDs and 30% mortality reduction because of NCDs, which hopefully we will be on track on that. Thank you.
Thank you. So now we are very curious how the civil society will help. Gerald.
Thank you, Bente. NCD Alliance is a global non-governmental organization with presence in over 150 countries. Was formed just before the UN General Assembly on NCDs in 2011. As you know, that was the second time that the UN General Assembly was being held for a disease or for a health cause, the first one being HIV. Since then, the commitment to advocacy and call for action for NCDs globally has increased, and we work very closely with our national governments, regional socioeconomic groups, and also with WHO. And in the last General Assembly, last month, which was held in New York, the Global Declaration document, which was produced, there was lots of lamentations on inclusion of this fact and that fact. But what came out for most of us is that most of the action should actually occur at country level. Political will and prioritization at country level for inclusion and prioritization of NCDs is one of the major challenges in low and middle income countries, where there are many competing priorities from education, agriculture, infrastructure development. But this is because most countries think that NCD, or health for that matter, is a cost. So our approach is that this health is an investment case, whereby the relationship between NCD and poverty is quite immense. NCD begets poverty, and poverty begets NCDs. And it's the poor in most of these countries who suffer more from NCDs. Most governments in sub-Saharan Africa allocate between 4 and 6% of the total government expenditure on health, which is a pally figure from 15%, which they all declared in Abuja Declaration more than 15 years ago, up to now. One of the bigger problems also is the inefficient flows of this little investment in health, in the sense that a lot of these costs go to administrative costs, and then most of the total health expenditure using the national health accounts in these countries actually come from out-of-pocket expenditure from households and also from donors. The government only contributing 40% to the total health expenditure. So more investment in health by governments is going to be the answer for not only NCDs, but also for other health challenges that face these countries, if we are to grow our GDPs and be able to foster development. So health is part and parcel of human development, and it's an attitude that needs to be taken very seriously. Use of the public-private partnerships efficiently, so that the public insurance and private insurance utilize both public healthcare and private healthcare efficiently, so that resources are not wasted especially in redundant private care facilities which operate at less than 30% in some cases of their actual total capacity. Frameworks for good private-public partnerships to involve the private sector, not only in curative services, but also in preventive and promotive health services. And most importantly, involving people living with NCDs as part and parcel of the policy process and the solutions for NCDs and those affected, on those who actually have NCDs and the caregivers for NCDs in this particular part of the world. I will leave you with that and leave the rest to the discussions to come.
Thank you so much, Anders.
Thank you very much. I'm sure that some of you were in New York as well now a couple of weeks ago, and possibly not just at the NCD meeting, but also at the TB meeting. And I think those two meetings are interesting because we have been for many years dealing with tuberculosis, and we unfortunately don't see a so positive development. There's an increase of 5% of new cases. But we also dealt with two other diseases, HIV and malaria, and we see major good progress. I'm mentioning this because I think, as Bente said initially here, it's important to get the perspectives right. NCDs, there are 40 million people dying in the world each year. 15 million people dying prematurely before 70. Half of those, or more, if I should follow Bente, die in low and middle-income countries, meaning 7 or 8 million. Compared to AIDS, TB, and malaria, 3 million. So twice as many in the same countries, low and middle-income countries. And we have, what is a challenge for us is that we need to continue to work on some of those communal diseases, but we need also now in some way to wake up and realize that we have a rapid, growing, exploding epidemic of NCDs also in low and middle-income countries. And that this is highly linked to poverty. It's linked to poverty in this country, it's linked to poverty in my country, but it's unfortunately also linked to poverty in very many African and Asian countries. And that is something, again, that we need to take in, that NCD and the development of NCDs is very much linked to what is happening in societies, societal development. We see economic development, we see technology development, we see social development, gender development, and a lot here is positive, but we see also changes in society that is not good for health. And that is one of my sort of major reflections from New York, is that this will require a totally different way and different approach. And the SDG then and the Agenda 2030 gives us a very good roadmap, because the MDGs, they were focusing on survival. Surviving, maternal and child survival, and then tackling some of the communal diseases. Now we have an SDG, which is not UHC. It's about ensuring that people can live long and healthy lives, and also having possibilities to benefit from well-being. But most importantly, we are focusing on ensuring that people can stay healthy. And we need now to begin to measure that people can live long and healthy lives, not just surviving. And what is the implication of this? Is that, of course, we need societies that are more healthy, that are enabling people to avoid the risks. Because what we can do is, of course, to ensure that we provide people with service when you're hit by an NCD. But what is even more important, and the only solution if we're going to manage this, both from a human, but also from an economic perspective, is to invest much more in prevention. And then we are no longer talking about the health sector. Then we're speaking about urban planning, we're speaking about food, agriculture, energy, education. Totally different ways of working for WHO to start with, but for all of us that have been working in global health for many years. So that was a key sort of home-take message for me from New York. And this is also then, we are, if I should say just one word about Sweden, we are presenting now a new plan for global health next Thursday in Stockholm. Our two state secretary for health and development jointly, and that is totally based then on Agenda 2030, taking the broader approach to health, and also taking the step of moving beyond aid. Our engagement from Sweden is, yes, we're going to continue to invest some of our development resources, but what we can do in terms of global health is much more than that, and that is what that plan is based on. Thank you.
Thank you so much, and the panel is doing so well. And I hope that you're really now ready to go with questions. So you should know by now that this is web transfer, so we are recorded, or maybe actually we are live. But anyway, so it's great when you want to take the floor, just identify yourself, who are you, and then if you can address your question to the panel, it would be great. And we would like more questions than sort of stories from your own country, unfortunately. So comments are well also, we would like comments as well, but try to be brief. So the floor is yours. I see some hands. It's difficult to see the hands from here, so I hope you who walk around with the microphones can see people that want to speak. I see a couple of people in the middle of the audience.
For Cole, I work on the Rockefeller Economic Council for Planetary Health based at Oxford University. One of the things that we're trying to do is find the economic incentives to invest in the health challenges, not only today and of the future. And it's extremely heartening to hear you talking about going back into the agricultural issues, the issues beyond health. That's very much where we're focused. One of the things that we're finding challenging is actually finding the data that links those issues with agriculture into, for instance, the top 10 causes of global burden of disease illness. So we can provide robust evidence for policymakers to say, this is where you need to invest. And one of the challenges that we think we're facing is that if you are investing in health, your starting point is the global burden of disease. And the quick wins for that are not necessarily the investment in environmental protection, in agriculture, in ecosystems, in natural capital. So what I would ask you is, if you have those data, how do we access them? If you don't have that data, how may we as a global health community try to put those figures together? And then what are the best levers we can use in the policy dimension to take those into the policy sphere so these are actually actioned, as you said, at the local country level?
Thank you. I think we take a couple of more questions before we have any answers. Next, please. It's a lady down here.
Thank you. Thank you, everyone, for really wonderful introductions and information. My name's Alicia. I work at a hospital in the United States, and I was curious, after having worked in the community health setting in Brazil, where they're facing a lot of concern about sort of sharing patient information from one community health posting to another. What sort of barriers have you faced getting people involved in digitizing and sharing their health information? And how do you anticipate broadening your scope in terms of that paranoia or just general concern or anxiety? Did that make sense?
Thank you. Anyone else at the moment? I see 3 hands, 4, 5. So maybe this lady in the front. Do we only have one microphone? Okay, thank you.
Thanks a lot to the panel. A very, very interesting insight. My name is Andrea Winkler, Center for Global Health, University of Oslo, but also Technical University of Munich. Before I went into global health, or in parallel, I was a neurologist. I'm very, very intrigued, of course, by global neurology, which now the new numbers coming out from the Institute of Health Metrics in Washington, the University of Washington, is actually that neurological diseases are becoming #1 of the DALI, so already actually #1 in terms of DALIs, but also second in terms of mortality. So whenever I listen to NCD talks, I'm always very intrigued and it's very fascinating, but I just wanted to ask the panel, where do you think that neurological diseases that are, that chunk that makes the mortality and the DALI is clearly non-communicable? It's cardiovascular and it's dementia, epilepsy as well. But anyway, so that it goes into the same direction. But whenever I read about NCDs, it's not really there, or some say it's included, some it's not. So I just wanted to have your opinion on that. Thank you.
Thank you. At least 3, 4, 5 hands in the audience. Yes, please.
Good afternoon. My name is Mai, and I'm a student of the European Master in Health Economics and Management. We're currently working on a project relating to NCDs, and we really feel that the children are the generation of tomorrow. I heard only one of the panel members speak about children and their role. So how do the other panel members view the role of children in battling NCDs?
Thank you. I think we can do another 2 or 3. We will manage.
Hello, I'm Bagher. Currently, I'm working on consultancy for the Egyptian Ministry of Health and Global Health Governance and Policy. It was interesting that I actually worked a bit for the policy analysis for the high-level meeting on NCDs and TB. And one of the things that came straight to my mind is what is the nexus between the momentum that happened on the international scene of global health as never before and the next year for the UHC high-level meeting. Would the panel members have any insight on how can we make a nexus or a kind of connection to head of states to have a map of clear action and nexus between the 3 high-level meetings?
Thank you. 1 or 2 more. It's one at the first row, but I saw at least a couple of hands back there. Yes, on the first row.
Okay.
Smart positioning.
Thank you. My name is Selma Karabey. I am from Istanbul Medical Faculty, public health professor. I would like to ask the panelist from Iran. I'm wondering about that. What have you done in terms of food industry in Iran? Thank you.
Thank you. So I guess we should... You have one more there? Yes, please, go ahead.
Hello, hi, my name is Krisan. I'm a doctor from Pakistan. My question is, what kind of difficulties do you face, like when you're trying to implement policies that are targeted towards non-communicable diseases in low and middle income countries as compared to first world countries? Thank you.
Thank you. Okay, so we have several questions. We heard from the panelists about bold ideas like learning from the financing industry and using data. We have heard about multisectoral, integrative, and also health literacy. We have heard about the importance of strengthening the civil society and also to have real financial mechanisms, and also that SDG is a great framework. So I would like to ask you, Anders, maybe to try to answer the first question about linking data from multisectoral spaces.
I think that especially bringing up the agriculture sector, I think is extremely interesting, and thinking around food production and food consumption, and to think about what incentives there are, and then also possibly then going one step even further up in sort of the thinking or whatever in terms of health and climate change. We have a huge momentum today thinking about what's happening to our climate. But if we go down back again, there's a lot that we can do actually when it comes to food production and food consumption. What is good for our health is good for the planet. What is good for the planet is also good for people's health when it comes to food. So I think we can and we should. I'm not sure where we can get the economic data, but there is a commission right now, Norwegian Foundation E together with the Lancet, and they're presenting the new data now in mid-January in terms of what is it that we could eat that are also within the planetary boundaries. I think that will give us some new data in terms of where to move so that we can ensure that both agriculture and health goes hand in hand. Because we need also then to look at incentives, and economic incentives I think is one part. But then you need also to look at consumers and consumers' behaviors. There's a lot here in terms of not just economics, but also incentives for political decisions, incentives then for the food industry, and incentives also for consumers. But that nexus in between food, health, and climate, I think there is really something that we need to work more on, which I know that you are partly engaging in. Thank you.
So maybe, Anders, you could also continue, because with your broad global experience, the question about NCD and the road to universal health coverage and creating a nexus.
I can't help then mentioning another Lancet commission that started basically now just last week, which is about the nexus in between UHC, more sort of healthy population and those broader societal sort of issues, and then global health security. Because also if you look at WHO, President's General Program of Work, their strategic plan, they're talking about 3 dimensions, and we need in some way all those 3 dimensions if we're going to achieve the overarching SDG. It's not enough with UHC. So in some way the nexus in between NCDs, I'm not sure that it's a nexus in between NCDs and UHC, is rather if we're going to be able to cope and approach and manage NCDs, we need to think broader than UHC would be my answer.
Mm-hmm. Thank you. Michelle, there was a question about, is it difficult to get people to share their data, not only, I think, individuals, but also governments? And do you mind answering that question?
Yeah, well, I think the short answer is no. And the reason for that is that what we do is people get something in return for the data. So we now have a model where payers in healthcare, it can be a government, can be with a national health insurer, but also a pharmaceutical company, is willing to provide funds to give people access to healthcare, but in return wants accountability on whether these funds are spent on a real patient with a real disease in a real clinic. If you ask people to share that data in return for access to healthcare, people are more than willing to do that. On a broader note, I think it's a very interesting discussion in general, the value of data. So I think we all, just coming here, for example, you use Google Maps, you take your Uber, we all give away our data in return for free services. And at this moment, the value of those data go straight to Silicon Valley, basically. And what you see is that Google, Apple, Amazon, they're all looking into ways to enter the healthcare market because obviously these data are, very valuable. And with technology, what you could also do is sort of turn that system around where you have people who become the owner of their own data. Communities decide which data, or individuals can be at different levels, governments even, they decide which data do we want to share, and you give something in return. So it can be access to healthcare, it can be money, you can think of all sorts of benefits. But right now what we basically do is we give away our data for a free app, and Google is worth billions, and I think there are different ways to deal with that.
Thank you, Marlene. Gerald, do you mind commenting on neurology diseases and also on children?
Yeah, I would like to start by saying that the issue of the 4x4, where we talk about cardiovascular disease, diabetes, cancer, and chronic lung disease, was the initial approach to control of NCDs globally. During the 2011 meeting, I remember us sitting in Brazzaville until almost 4 in the morning because of 9 other diseases which were proposed to be included. So to be focused, sometimes we look at diseases which have common risk factors and which have common approaches for solution. So neurological diseases were put together with cardiovascular disease. I know you mentioned those which do not involve cardiovascular disease. And we also recognize that mental illness was quite important in that part of the world. And recently, you know that mental illness have been included in this. Now, neurological and mental illnesses and cardiovascular disease have a lot of commonalities in between. There are a few diseases, however, that we recognize amongst the neurological diseases, which may not necessarily be connected to mental illness or neuropsychiatric illnesses or cardiovascular disease. And not to be completely exclusive, the concept of controlling NCDs do not lie in specific treatments of specific diseases, but rather looking at common risk factors that can help us in a more comprehensive way prevent and control diseases, and the healthcare system structures of chronic illnesses that can make access to care, and good care for that matter, quality care, be available to all. So without specifically mentioning each and every disease, as was our dilemma that night when we were presented with so many diseases. Now, talking about children, we do recognize as NCD community and NCD Alliance that NCDs occur throughout the life cycle. Indeed, I usually joke, from the time that a boy looks at a girl with the intention to marry, NCDs have begun. Because one may be a sickle cell trait and another one a sickle cell trait, and they have a 50% chance of having a sickle cell child. So that's really when it begins. And antenatal life also affects NCDs. Early childhood feeding habits and infections affect NCDs. School life, adolescent life. So NCD throughout the life cycle really is one of our recommendations. As we speak, as part of NCD Alliance, NCD Child, which is an organization that specifically deals with NCD in children, is one of the actual members of the NCD Alliance as a major partner. And I would like to go into all the details of the programs that are planned and some of the research activities that are planned and are ongoing. But NCD, the children and NCDs are one and the same thing. Not just as future NCDs as adults, but they are specific diseases for each stage of life, which are NCDs by themselves.
Thank you. So you got a very specific question on food in Iran. And I think we will come back to the low and middle income countries in the end. I think Svetlana will address that in her closing remarks. And then, so we will listen to Amir, and then we will move on to the next topic, the next panel.
Thanks, Bente. Very relevant question. Unhealthy diet is one of the main risk factors, which is a member of 4x4. And just to summarize what we have done two main initiatives. One is at the population level, and another one is at the industry level. For the population level, which is more difficult to do, is changing how people eat, how people behave, how people produce their food, and this kind of stuff. Our National Action Plan for Prevention and Control of NCDs has a very ambitious goal, which is very Iranian, and this is 0 trans fatty acid by 2020. So we have 2 years to go to absolutely delete trans fatty acids from the existence in our country. In order to do that, we have started to do a number of campaigns and initiatives at the population level. The first one is the health ambassadors, which I mentioned. So we try to somehow change the taste of kids in order to have healthy food as a kind of tasty food. And then they have breakfast in the mornings, and they prepare food, bring school, and they have the competitions. We have, in the city of Tehran, for instance, we have 374 neighborhoods, and each neighborhood has a health club, and the health club preaches people and teaches them how to have healthy cooking and this kind of stuff. And then we use campaigns, for instance, celebrity campaigns, in order to increase the health literacy of people, and this kind of initiatives at the population level. And one specific thing that we have done is we have almost 35,000 health houses across the country who provide primary healthcare services for people. Since 4 years ago, when we started our health transformation plan, we have allocated one master of nutrition and one master of mental health as the providers of healthcare for NCDs, mental health and nutrition. And those people are not just responsible for clinical nutrition, they are responsible to spend 2/3 of their time in the community, go to the mosques when people gather, go to the schools, to the shops, and try to somehow be with people to change their habits towards the tasty, towards the healthy diet. This is what we have done at the population level, which is a long way to go. At the industrial level, which is a bit more easy to do, one of the things we have done, for instance, salt reduction. Iranians, before the National Action Plan, we used 12 grams of salt every day, which is much higher than the 5 grams that the WHO says. And the main sources of salt are bread, then cheese, and then the yogurt drink in Iran. We started with these three main initiatives, and going back to the question from Oxford, we identified that the reason that people eat bread, we eat almost 320 grams a day of bread, and the reason that they add salt to the bread was because the gluten quality of our wheat was really weak. So we liaised with the Ministry of Agriculture and the FAO organization in order to address this challenge. And then we went to the bakeries. I remember I was in the session that our Minister of Health had with the thousands of bakeries from across the country to ask them to collaborate in this. So in that one, we are bringing the salt down. We have reached to 8 grams. which is almost 50% reduction, and we are moving towards the less than 5 gram. We have the same programs of other things, which I don't have time to go through that. Thank you.
Thank you. And actually, it was a very nice sort of segue over to the next session, which is how can we accelerate? You have already heard from Svetlana that we have the political commitment. It's time to act, and we actually know what to do. We even know the cost of many of our interventions. And I'm sure all of you use Twitter, and I hope you are really tweeting a lot just now. And you know that Uzbekistan just did their investment case. And at the moment, 4.7% of their GDP is actually the cost of the current NCD situation in Uzbekistan. And we know that if they use the best buys, they will be able to avoid 100,000 deaths to the cost of 330 million in the next 15 years. So it's real big figures. We also know that childhood obesity, which is the European region most rapidly increasing, I would say, disaster. We have like 50% of our young children under 9 years are obese or actually overweight. And we have seen that countries like Portugal actually are able to reduce with 7.2%. So we have good examples. So the next question is to the panel. What is the key elements to actually accelerate and go from pilots and very small examples to country-wide implementation? And what does it take also in kind of leadership? What do you think is the most important factor to accelerate? And this time I will start with Anders and go the other way around.
Thank you. I think this is a very interesting question. And what is behind that question is as well our understanding in terms of why is it happening or why is it not happening. We know what to do, but why is it happening or why is it not happening? What are the incentives behind? And I think we need to understand that better than what we're doing today. 3 sort of stakeholders: politicians, private sector, and people. What is it that makes politicians take certain decisions? Why were you okay in Iran to introduce that policy? Why are certain countries now introducing taxation on tobacco, sugar, and on alcohol? Some other countries are not. But understand that behind, because we can say as technical people that just use the evidence and then just do it. That's not the case. There's a science also to politics, political science, but to understand better the incentives behind. Why is it so that peer pressure among politicians, suddenly now some or quite a few politicians are beginning to take actions on some issues relating to the climate, like the use of plastic? It's moving rapidly across the world today, no more plastic. That's happening. And politicians feel that, yes, this is something that my voters will like. Second, on the business, what are the incentives then for the private sector? Private sector business needs to earn money full stop. That's fine, as long as they pay taxes as well. But what are the incentives for private sector actually to produce healthy products? Because there are many parts of the private sector that are actually producing healthy products. And what is the dynamic that will enable the private sector now to change from unhealthy products, which they're doing a lot as well, to then healthy products? Of course, regulations can help, saying that we need to put a label on this product to tell it's healthy or not healthy. That helps. But what I think is most important, and that is my third and last, are the people. What is really the incentives for people to make more healthy choices? And how can we understand better behavior science? Using private sector sort of nudging? I mean, how is the private sector actually influencing people to make a certain choice? So how are we influenced as people? Nobody is smoking here today. Gone. Eating healthy food, looking outside. What's not 100% healthy? No. So that we are still not there with what are the kind of values, cultures, the peer pressure. So my main message is here, if we're going to be successful, we need to understand better the how issues, not just the what issues. What are the incentives? What makes a politician take a certain decision? What makes a business leader, a private sector CEO take a certain decision? What is enabling us, people, to take the decisions? And we need more science, more political science, more political economy, more behavior science to understand that even if I think we know a bit already, just what we heard from Iran, for instance. Thank you.
Thank you.
Yeah, thank you. I'll pick it right from there. From a national and regional advocacy point of view, therefore, we need to also change tact in the way that we advocate and the way that we use research evidence to make policy briefs that endear to the decision maker to make the decisions that we'd like them to make. And therefore, I think from our side, we may require to be a little more innovative in packaging information that is available, especially evidence, to ensure that our decision makers invest more in health. Because in mostly low and middle income countries, there's too little being invested in health. So the message that investment in health is a good investment case, I think is one of the things that we require so that more resources are put into health. And then the second one is the multi-sectoral approach. Most of the risk factors for NCDs actually are driven by factors outside the health sector. So realization that what happens in agriculture, in physical planning, in trade, actually affects NCDs, and mainstreaming NCDs in decision-making process in government becomes very important. And one of the recommendations has been to have an intersectoral coordination committee within government so that we have health in all ministries, especially NCDs. And these intersectoral coordination committees placed at the highest seat of government, preferably where coordination of the cabinets, the different parts of the ministries and cabinets can happen effectively. And then, most importantly, involving people. Advocacy through people, a people-driven political process, whereby people living with the NCDs are part and parcel of decision-making process policy from its beginning to the end, and implementation and monitoring framework, so that there's a face to all these things. And you'll be surprised that if you involve people living with the NCDs, and most of them are actually in the seats of government, then they may have some feeling that this is not happening to somebody else, but is actually our process and not just the process of people living NCDs are a different group of people and decision makers are a different group of people. It's a legion between leaders and people who are being led that we can come together and realize this is a collective problem and that solutions lie within people living with NCD, some of them who are in decision-making positions. And that's what brings me to champions. Champions within government, champions within global leadership who not only are affected but also are able to make decisions at various levels. Thank you.
Thank you. And before Amir, something very interesting happened during the plenary session in UNGA this year, because Tedros asked everybody that either was affected or themselves had an NCD. So we could do the same thing here. So I would like you to raise your hand if you either are affected or you have yourself cancer, diabetes, heart or lung diseases. Raise your hand, please. If you're affected, meaning that maybe a relative, your mother, your father. So this is very important. This is not something that is with the others. This is actually with all of us. So we continue, Amir.
Thank you. I think I bring the perspective of the member state of WHO in answering this question, which somehow responds to the previous question from Pakistan, the difficulty of making this kind of decision at the high level. I think after the Global Action Plan, we have made progress in 3 dimensions. And in order to move forward and scale up NCDs, you need to have these 3 dimensions together, which is the government or politicians, which is people, and which is academy. In terms of governance, you need to advocate for NCDs. You need to make your high-level people understand that this is the main killer of people. This is the main barrier to sustainable development. And one of the best ways of doing that is talking in the language of numbers and investment. So you need to show the policymakers, if you don't invest in NCD, or if you invest on NCDs, you have these consequences or you have these good results out of that. These are the numbers which which really help. So, and in order to do that, you need to have a kind of established academy, a surveillance system, and gathering data to do that. So what we did, we went to our academic institutions and we somehow utilized the capacity of our academic institutions for teaching, for training our managers and policymakers and our technicians for NCDs, and doing some research which is still continuing, and liaising with international partners for doing global research on NCD and doing comparative analysis to learn from each other. One thing which I want to a bit more emphasize is people. In the context of low and middle income countries, if people want to contribute to health system, even in the context of my country, they mostly do charity. They contribute to the health services, the provision of health services. What we have done, which I'm really proud of, is we have somehow transformed the governance of our health system. 2 years ago, the Minister of Health established a new deputy within the ministry, which is Deputy for Social Affairs, whose main duty is liaising with people for social accountability and responsibility, mainly for NCDs. I'm pleased to say that in 2017, February 2017, we held our first ever National Health Assembly, attended by 2,500 people and attended by the President of the State and 8 ministers and high authorities from WHO. Then the President and the Ministers of Interior, Minister of Foreign Affairs, and everybody talked about health. And the people had their own say. And then during that, our president asked the Minister of Health, you need to have this health assembly at the local and provincial level. Ever since, we have had hundreds of health assemblies across the country. We are moving ahead to have decision-making for health by people. My main message is, in the context of low and middle-income countries, if you want to institutionalize your system for tackling NCDs, you need to bring people at the front and at the heart of that. And there is no other way than you make them to understand that these are them that they need to invest in their future. And one of the ways to do that is this. And that my last point is about the healthcare delivery. Unless you integrate the primary health, the NCD in your primary healthcare facilities, which reaches out everybody across the country, you cannot have the good prevention of non-communicable diseases. So you need to invest on that as well. Thanks.
Thank you very much. Marlene?
Yeah, well, I couldn't agree more on the incentives. I mean, it's quite clear that there is an investment case, but who is going to take the initial risk of investment? Because the benefits are very long term. So I think government is crucial in sort of changing the incentive such that the other players in the sector can do their thing. So it can be a sugar tax for the industry to make it more profitable to invest in healthy food instead of soda. It can be allowing different financing models in the healthcare sector. So, for example, with the move from fee-for-service models to more outcome-based models, you see that it becomes also interesting for healthcare providers to truly invest in prevention because they get paid by the outcome and not just for doing a service. And for example, in the US, there are a few organizations that do population health financing, so they take up the full financial risk of their population. And what they do, based on, again, technology and data, they use big data to predict who's at risk to get ill, who will be high cost, and then they put all their prevention resources at those people. And I think that can be also an incentive to have a broader perspective. And lastly, on the individual level, again, coming back to the mobile phone, I mean, if Facebook can alter our voting behavior, or at least in the US, it should be possible to also change behavior from a health perspective. So at our institute, we have this International Chairs program, and our first chair that we appointed was Dan Ariely, a behavioral economist. And the global health community was kind of surprised that why would you appoint a behavioral economist? But it was exactly for this reason. They know how to nudge people into certain behavior. And with a mobile phone, people are spending almost 24 hours a day on their phone, so you can hack people's life and you can gently push them in the right direction, I think.
Thank you. I don't know if this is good or bad news, but anyway. So in this room, I know we have people from private sector, from academia, from government, from all kind of stakeholders. So the floor is yours now. What shall we do to really scale up and make this epidemic stall and make sustainable economy and healthy life and well-being in countries. Floor is yours.
Thank you. My name is Dorothea Kantak-Chan. I'm with the Global Alliance for Chronic Diseases, which is an alliance of health research funders jointly investing in implementation research in low and middle income countries. And my question is, it goes a bit to what Gerald said, how researchers really need to work hard to create great policy briefs and to reach the policymakers and help them in their decision making. And my question to the panel is, from your experience, how can we make sure researchers and policymakers speak the same language? How can we get the evidence that they generate actually to the right people? Thank you.
Thank you. I see a couple of hands in the middle of the audience, please.
Thank you. I'm Ali Jafarian from Tehran University of Medical Science too. And my question to other panelists, other than Amir, who is from Iran, is that is there any other experience about the community role in NCDs? As we all know, 75% of these issues, of health issues, is related to the community. And unless we do something that they take care of themselves, we are not going to succeed. Is there any other, experience worldwide? Thank you.
Thank you.
Excuse me.
1, 2, 3 hands in the middle there.
I'm Dr. Nick Naum, permanent member of Iranian Academy of Medical Sciences. Thanks for very rich talks. Talking about food security and talking about food safety, one important subject is effects of pesticide residue on health. Food safety is one of the main components of food and nutrition security. Safe food means free of pesticide residue, high amounts of nitrite and nitrate. Overusage of pesticide and food fertilizers has unfortunately created numerous problems: cancers, childhood cancers, birth defects, neurological defect. The most vulnerable groups are pregnant women, infants, children, and since children's bodies are small, they receive greater doses of residues by consuming given food than an adult would. To address this problem, we need legislative and non-legislative and other approaches.
Thank you.
Like research on biopesticides and research into alternative pest control methods. Thank you.
Thank you.
My name is Bashir, a recent graduate from the Institute of Public Health in Heidelberg. So my question goes to the speaker from Russia and also Kenya, and the first speaker also that spoke about investment in NCDs. I want to take, for example, the African Union as an example. You mentioned like the Abuja Declaration in 2001, where African leaders, they committed to put 15% of their national budget. But as of today, I think maybe just 10 countries have done that. We all, two countries, okay, 2 countries, thank you very much. So we all mention, like, I've had it in a lot of conferences, seminars, African leaders, they have to commit. But these are just paper and talks that keep on going on, conferences and every year. What is WHO doing presently to make sure that African leaders are not just saying this on paper, but are also putting this? And as an advice, as a young professional, how do you think we can also advocate for this in low and middle income country? Thank you.
Thank you. A woman at the front row, and I see 3 hands in the middle of the audience. If you want one more microphone, you can for sure have one of ours. Okay.
Hi, over here, sorry. Or was it not my turn?
Yes, please, go ahead.
Yeah. No, not anymore. Yeah, now, thanks. Over here. Christian Franz is my name. I work for CPC Analytics, a data and policy consulting firm. But we are also facilitating the WHO community of practice on commercial determinants of health and on NCDs. So what I'm missing out here is a bit the globalization perspective. I mean, we have multinational corporations that are active throughout the world with their marketing strategies, with investment, with policy influence. And these are all outside the health sector. So how do you plan to deal with that, to incorporate into your national strategies? Thanks.
Thank you. I think we will have 2 more questions and then we start to answer.
Hi, my name is Chloe Cassis-Crowe. I'm from Dublin and I'm a dentist working for one of the largest dental chains in the world. We've talked about multiple different ways to prevent NCDs, and of course I would love to be able to prevent anyone from eating sugar ever again, but I think the conversation we're having really is about citizen autonomy and looking at what they're doing in China with Ping An, with Alibaba's co-founders now going in with an insurance company and in an app, such as things that are marvelous. They're creating a one-stop healthcare system. How do we begin to shed light on the risk-rewards benefits of citizen autonomy?
Great questions. We have a couple of more. Please go ahead.
So you was the first. Sorry, here's one also. She was first. So.
Okay, so one in the middle and one with you. Yes, please.
Hi. Justin Coonan from the AIDS Council of New South Wales in Australia, but also from the steering committee of the UHC 2030 partnership. I was really interested in the comments from Mr. Nordström that when we're talking about NCDs, UHC might not be enough. And then also some comments from our colleague from Iran about the importance of primary health care in achieving progress on NCDs. So my question is around the relationship between UHC, primary health care, and progress on NCDs. And I guess where I'm coming from is how can those of us who are working towards UHC be most useful to the NCD community?
One more.
My name is Franziska Brasse. I'm still a student at University of Oxford, and I was very interested to hear about how it's been possible to decrease the amount of salt that people are eating. My question is, how difficult was it to actually get the commitment of other people to work together and achieve this goal? You see different things in Brazil, for example, Kenya, where actually obesity and things like this are going up because the middle income people group is rising, and so people can afford more products which they weren't able to eat earlier, but which are high in sugar and so on. And their companies such as Nestle are very successful in their campaigning of showing that this apparently is healthy food. So how often is there a willingness by the government and also, I guess, companies in these countries to work together in achieving this goal? So how difficult was it to get this result? Thank you.
Thank you. So I'll try a distribution of the questions in between us. So I would like Gerald to comment on the community role, and also, even if the question was addressed to WHO, I would like your opinion as well, why we cannot get countries to really invest as they promised so many years ago. Are you okay?
Yeah, very difficult questions. For the community one, we do know, for example, that there is a group of people who worked in Kenya together with certain private players to educate people living with NCDs, especially one organization which is called Defeat Diabetes, and another one called Stroke Association of Kenya, and another one was KENCO. KENCO is a conglomeration of about 25 cancer, patient-led cancer organizations, because as you know, there are very many cancers. And the issue was just one, for them to form branches in the community where people living with the different NCDs can form groups. And within these groups, they would do two main things. One is they become the voice of prevention in the community. And then two, they advocate for two things. One was access to essential medicines for their various NCDs through forming sort of like patient-led registries to assist their county governments to be able to quantify the requirements and perhaps also support the supply chain. And then the second one was also to advocate during election period for making this an election agenda. The budgets there are usually historical, so to get an item to become a recurrent item in the budget is quite difficult. So this is one way of mobilizing the community. The second one was then
how to get countries. It was African countries mentioned, but actually it's
Yes.
not only a problem with African countries.
That's the difficult one. How to get the African countries to bring up their contributions to health. And you mentioned the Abuja Declaration and all that. There are some countries, it's actually a question of political commitment, and also the civil society organizations organizing themselves in such a way that that so-called election that comes every 5 years begins, because a lot of their plans are 5 years, because after 5 years, they'll have to go back to the electorate to get elected. So this is why we're actually involving people living in the NCDs to go into the communities and make NCDs an election agenda. Because every 5 years, they'll need the voters. It's difficult to get a project on NCDs that can be achieved in 5 years and be endurable, especially when we talk about prevention. Prevention programs are not sexy. So most of the people talking about universal health coverage in most of these countries will bring in X-ray machines and ultrasounds. And as you know, those are not the solutions to NCDs because they are more visible to people, so that they'll say, look, I brought you ultrasound machines. So if we use the electorate as people living with NCDs who require to be listened to and who can advocate for these legislations, I think it will be a more effective way.
Mm-hmm. Thank you, Gerald. I would like to add a couple of things to this, because probably some of you know that we have something called a PEN package. So we have actually packaged modules on how to trigger, how to sort of describe what is the minimal requirements at community level. So this is something we advise many countries. So that's one intervention. You will also see, if you go on WHO web pages, that we have a lot of case studies, more and more, and this is really a requirement from the member states, because they need to see these kind of tools sort of in a setting, in a context. So even if it's not really their own context, this is really the way to learn. And I could also mention we are doing demonstration project at community level with health literacy to try to see how can we sort of combine empowerment with the different tools from WHO. So these are things. I'm sure that Svetlana also will come back to the financing, but I would like to add that I think WHO's with the whole of the UN, all the UN agencies now doing the investment cases, showcasing that this is the cost of inaction, while this is actually the return of investment for action. This is things that probably could inspire for a bigger sort of contribution to health. That's one of the options, at least. So we continue with the questions. So we had a question about actually closing the research gap, focusing more on implementation research, and it was nice because Svetlana and me were, and Gerald also was on lunch, invited by Detlef Ganten today, which had the same question. So this is really on the forefront. So I don't know who would like to answer this. Maybe Amir, would you like to answer something about the research gap and how to trigger this?
As I said, I mean, the gap in the policy and the research is always there. So the way that we do that, I mean, the experience of Iran, I can mention this as a case study, was a group of researchers. In Iran, we have a kind of unique governance of the health system, which is our medical education which is integrated within the service. That's why many policymakers are in the ministry, and at the same time they are senior academics as well. And this somehow is one of the ways to go around this way, and the narrow ways to bridge the gap between the policymakers and the researchers. For the National Action Plan for NCDs, what we did was we were a group of researchers and we were at the ministry at the same time. And we get exposed to the experience of WHO for the Global Action Plan. And actually we managed to establish with the Vice Minister for Education, who is the chief, who's a very kind of famous endocrinologist himself, to establish a committee. And this committee is called INCDC, Iranian National Committee for NCD. This is led by the minister. But we were very careful and prudent to select the members in that committee who are the individuals who are very famous and pioneer researchers, in combination with people who were pioneer policymakers. And INCDC is in charge of the policy making. And this is, if you like, in health policy, we call it advocacy coalition framework model, coming by Paul Sabatier, which means that if you want to have a policy going forward, from the beginning you establish a committee between the researchers and the policymakers, so they grew up the policy together as if it is their own baby. So we did that one for INCDC, which was awarded just a few weeks ago in the UN General Assembly. And this INCDC is a good composition of policymakers and researchers, and this is very, very high official, because whatever happens in NCD since 2015 should be approved by this committee. And this committee is in charge of overarching policy making, implementation, monitoring and evaluation, all these activities. And that bridges somehow the gap between the policymakers and the researchers. And most recently, what we did, almost from say 1 year ago, we have started ERA-PEN. Bente mentioned PEN strategy. We have tailored PEN for the Iranian context, and we have started to pilot that, which is called ERA-PEN, PEN for Iran. And in order to do ERA-PEN, we had some researchers who were against those strategies. But we managed through this to bring all those researchers to discuss, and now ERA-PEN is becoming a kind of national agenda for risk score assessment and early detection of some risk factors of NCD. So my suggestion is bringing the researchers and policymakers under one roof for decision making and doing research for NCDs.
Thank you. We have only a couple of minutes before we have to leave the floor to Svetlana to close. So the question about commercial determinants of health. Thank you, first of all, that CPC and Graduate Institute, together with WHO Global Coordination Mechanism for NCD, to establish this community of practice. Those of you who had the pleasure to be in the global dialogue on financing for NCD hosted by Denmark in April saw that this question is maybe the most sort of, I would say, important question in the NCD agenda, and maybe the most immature. There are no question at all, and it's mentioned sort of implicit by all the speakers as well, that there are sort of the influence beyond health, and definitely by big food and environmental sort of risk factors, and also true finance, that many of the things are actually happening. And you mentioned Google as well, both as a threat and a possibility. So I think we just have to tick that now, that this is super good, that this is happening. And for all of you interested in this, it would be possible to follow that work through the year. So we have, I think, a couple of very specific questions. One was about food safety. I don't know if you will capture that in your closing, Svetlana. Do you want to do that? Or should I comment on it as well? I mean, it was more like a comment, and of course it's extremely important, and we have International Agency for Cancer Research who has been focusing on pesticides and other sort of food risk factors for cancer for years, but we also have a specific department under the leadership of Dr. Akselrod who is looking into these questions. When it comes to the question of more specific details around salt reduction, I don't think we have the time at the moment, but I'm sure that Amir will be more than happy to have a bilateral discussion with the person who asked the question. And then the last question was about autonomy and sort of integration from the person with the link back to the dental. I don't know if Anders would like to answer that question before we leave the floor to Svetlana.
Thank you. I can say one word about UHC as well, as you asked about that. Let me do that first. I think UHC is extremely important for tackling the NCDs for three reasons. One, that if you do UHC properly, you need to define the package of both preventive, promotive and curative services. And by doing that, then you need to get your priority right. You need to know your health situation. Second, UHC is a way of really getting more integrated, close to people service. And thirdly, this is a way also dealing with the financing. And the big challenge we have in terms of financing is out-of-pocket expenditures, to try to find a more fair system, and that is really what is within UHC's sort of scope and mandate. So really important. But why I've said that is not enough is, of course, to deal with issues that we're talking about now in terms of the agriculture, the food production, a lot of things that is happening beyond the health sector, which are the underlying and absolutely necessary sort of societal change that we need to see happening in order to be able to prevent NCDs. In terms of the issues around citizens, I think that's extremely interesting because it all comes down to people in some way. How is it that people are taking a certain decision? Knowledge, it's not enough, but it helps. It's important. You can look at smoking. Food, people are today, I think, quite confused. Then you have the issue around resources. And here I think we can do different things in society. We can increase prices through taxation. We can work with the market. If there is more of a demand for a healthy product, prices will come down. You can work with insurances, the incentives, the premiums. I mean, there are many ways that you can deal with what I call the resource issue. Do you have access? Can you afford? Is it physically possible actually to have access? There's a number of issues, but let me finish to say that what I think is most important here is not knowledge, it's not resources, it's values and cultures. Because it all comes down to that. It's not enough if you can afford. It's not enough if you are pushed through the economic incentives. It all has to do with our culture, values, what we appreciate. And that is, of course, the most difficult one. And let me finish then coming to the communities, because I think we have a lot to learn from how we have worked on behavior change. HIV/AIDS. We have done a lot of work here, and I wouldn't say that we have been successful, but still there's a lot of knowledge, and there's a lot of structures today trying to work on behavior change. Or the last thing did now for WHO was to be the head of the WHO office in Sierra Leone during the Ebola outbreak. Major behavior change community work. We had social anthropologists working for WHO to understand why are people behaving as they are. So I think we can leverage, we can build on, we can connect more to work that is already happening in terms of community engagement, people and behavior change. Thank you.
Thank you. So, Svetlana, the last minute is yours.
Thank you, Bente. Thank you very much for our panelists who really give these interventions and show the different examples from the perspective of the country level, from also the civil society, from private sector and academia. And thank you very much for audience for your question, comments. It showed that it is a really good time and very timely that we are discussing it, and this a great opportunity for us to go ahead. So what is my conclusions? I want to say a few words about it. Of course, we should emphasize that only multi-sectoral collaboration and multi-sectoral actions is very important. And as it was said by the participant from Iran, that is a very good example and championship that NCD agenda can't be solved only by health. And that is why it's important to involve all sectors. And we've heard today different interventions from the audience, that it should be from the food security, from the nutrition, from the education, and of course from the finance sector. And that is why for us it's very important to put the NCDs on the high political agenda. That is why we use this opportunity of the third high-level meeting, and we discuss it with the head of the states. Secondly, that I want to say that it is that we should first to change our personal habits, and we should prevent NCDs. And there are 4 main risk factors: the harmful use of alcohol, tobacco, unhealthy diet, and of course the less of physical activity. And we should start do ourselves and change to our habits and to prevent NCDs. But of course it's very important the healthy environment, and that is why we need to provide the activities from the government to make our healthy environment to prevent the NCDs. And that is why we have these WHO interventions, and we call it best buys, and we have 16 best buys that could be implemented by the member states. And the question about the low and middle income countries that you raised, that is really important, that investing $1 in the best buys could be returned by $7 by 2030, and that is the evidence-based. And also implementing the best buys in the low and middle income countries could save almost about 10 million lives by 2025. So this is the important intervention, and this is our WHO role, to provide these best buys, to work with the countries. But of course, and it was also raised, we need civil society. Only by this group of this enthusiasm we can do it together, because alone it's nothing, only together. The third important point that I want to say, it is technologies and research in the area of prevention and treatment of NCDs. And we should use different technologies that we have to implement it in the countries and to get the access to all medicines and to new technologies that we have. And of course, that is the main point, it is the young people. And I want to use this opportunity and to thank all young people and students who are attending this important summit, because for us, this is the future, and you can provide through your community. This is important agenda of NCDs. Thank you very much that you are attending these meetings. Thank you for your involvement. Thank you for your attention. And we hope that we will continue our great collaboration together. Thank you very much.
Thank you, and a big hand to the panel as well, and to yourself. Thank you very much.